Okay, so today we're going to talk about the cardiovascular system, still in it, and we're going to talk about heart function and the cardiac cycle. So most of what we'll be talking about kind of is the cardiac cycle, but we are going to continue talking about the electrocardiogram, ECG. So we're still talking about that's going to be included in that overall cardiac function, heart function. Okay, so we've already seen this slide before. So this is a graphic record of the heart's electrical activity. That's what an EKG or ECG is. ECG, spelled the English way, I guess, and electrocardiogram K, where it was developed and invented, I guess, was with a K. So it started out being called EKG. There's your history. So the reason is a composite of the electrical activity, not a single action potential. So we'll just say this very quickly. The P wave is atrial depolarization of the atrium, and the QRS is ventricular depolarization. Okay, so repolarization of the atria happens in here, but it's just kind of hidden. That we'll see kind of in the next slide with the Netter diagram. And then, so ventricular depolarization is the QRS complex, and then the T wave is ventricular repolarization with an R. Okay, so when we say that, it's a combination of all of these things. So all of these things are happening. So we see the SA node depolarizes, but that's barely seen. It's seen just like right here before you have depolarization of the muscle. So that's not even a signal that can show up unless you have like a very sensitive EKG. And then it wouldn't even be part of this P wave. So this P wave, you can see, is mostly the green there, and that green is the atrial muscle. So the depolarization, that's why we say it's the depolarization of the atria. It's the depolarization of the atrial muscle. So that's what we see. And then the rest of this is all just this gray color, and this gray color we can see here is the ventricular muscle. And so that's going to be the biggest signal. The rest of the way. And everything else, you know, if it's electrical signal, it's an electrical signal. The nodes are electrical, the bundle branches, all that stuff is electrical, but they're very small signals, so they don't stand out the way that the atria depolarization does and the ventricular depolarization, repolarization, the way that they do. Okay? So how do we measure an EKG? So this was developed, Einthoven's triangle. And this was found that if you place leads, right arm, and then the left leg, you can kind of, especially with lead 2, you can see the direction of flow of these electrical signals, okay? So any kind of voltage change that happens in here, this is like sensitive to just the voltage changes. And what they found is that if it's moving toward the positive electrode, then it's going to have an upward deflection. If it's moving away from it, it's going to have a downward deflection. Now, I drew that arrow through the middle because things start at this SA node, really. Okay? And then they kind of move down to the AV node, which is here, and then they move through the ventricles. All right. So the ventricles kind of give us a deflection. Okay. So, but in general, like when these are firing, they're kind of firing in this direction. Okay. So they're still kind of pushing toward and now we get up here where they're kind of firing in other directions, but that's why you have those little I guess downward deflections along with these guys here. Okay, it's because it's kind of going around in a circle, but in general the signals are moving toward the positive of lead 2. Okay, so you can see lead 3 and lead 3. You're going to have, I mean, the signals are kind of going that direction into the, so you'll see a little bit of a different signal, and you can kind of analyze these when you get like a 5 lead or a 12 lead, especially EKG. You can really kind of analyze these and see how they make a difference. So it's really tricky to place them correctly. That's what gives us consistency when we place them. So really more leads gives more information. So one thing that we have to be aware of is that there is a 12 lead EKG. Now it's going to have the right, left, and then the lower lead, upper leads to left leg, left arm, right leg. But it also has this sort of circular where the leads kind of go around the rib cage, the chest cavity, in this direction. So we have kind of a horizontal display, and it's checking the heart in this direction horizontally, as opposed to just this direction in kind of the vertical or the frontal plane kind of a section. This is a cross section in this direction. So it gives us a different way to look at the rhythm or the pathways that these voltage changes are taking, that the depolarization events as the heart contracts, as the heart muscle contracts. So you can kind of see things, you know, if you're comparing lead 1 to lead 6, you're kind of getting a signal across the heart in this direction, and then you kind of can move through different parts of the heart to kind of get a better idea. Okay, let's see. So this is our 12 lead. That's the big one that can give us the most information. 5 lead gives us a little more information than the 3 lead. So what do we find out from all of this? Then we find out that there are some abnormal rhythms. So there are some that we want to talk about that you just need to know, like sinus bradycardia. So we use this word sinus because we're talking about the SA node. So that's where it originates. If it originates in the SA node, we call it a sinus rhythm. Sinus rhythm. And if it's originating in the SA node, but it's slower than 60, we say it's sinus bradycardia. So brady meaning slow. Sinus tachycardia is if it's over 100, tachy meaning fast. Okay, so that's just the term, but you know, people say he's Brady or she's tacky or whatever, and they'll mean sinus, but we can also have things like tachycardia. You know, that can kind of be scary because if you're talking about ventricular tachycardia, that's not sinus, and that's a pretty serious rhythm. Okay, but yeah, just keep that in mind. Sinus means it's starting at that SA node. Fibrillation occurs when there's no coordinated, synchronized rhythm. So we think a lot about like AFib. So if we have the SA node up there and then the septum's in between, and then it kind of goes down here to the AV node, and then you have the very poorly drawn heart here with the ventricles and the atria. So what can happen is that you're supposed to have a coordinated contraction that goes right into it spreads across nicely across the atria, and then it moves down into the ventricles, right? So that's the way it's supposed to work. So what can happen with fibrillation is that, let's say that one of these muscle cells over here says, hey, I want to be a, let's see, I've got something sticking up there. Says, I want to be an autorhythmic cell. I want to be a pacemaker too. So maybe it starts to depolarize, or maybe a stray signal moves through, or maybe it doesn't get a signal, or you know, whatever. These guys, a lot of times these guys will say, hey, I wanna depolarize. And then you've got depolarization that's kind of happening all over the place. And if we look at the depolarization, repolarization rhythm, if the SA node's trying to keep it up, but these guys are kind of off balance, then we end up, instead of like having a nice P wave, we end up with just what would be seen as a fibrillation. Okay, so AFib usually kind of looks like this, and then you have your QRS, and then you have your QRS, and then maybe a little bit of a delay, and then your QRS, and so your rhythm is kind of, you know, it's not very consistent. So instead of these guys marching across at nice pace, then it's like, oh, well, this is delayed, this one might be early, and then this one's delayed. So your atria aren't really keeping a good rhythm. However, it will get a signal across to the ventricles. It just does it in a very uncoordinated, and see this big gap here, way. So that's, you know, when, I'll tell you, when a watch, like watches, we have EKGs on our watches now, and when they test for fibrillation, it's really hard for the watch to have a good enough, ooh, that all went away, a good enough resolution to say, is there a P wave and a T wave? So the T wave is going to be there too, by the way. I didn't mean to imply that there's no T wave. These do have T waves. But with fibrillation, what happens is that the spacing of the QRS is off. So you have kind of these weird kind of spacings, and that's what they're really looking for, because they can get a good signal. Watches can get a good signal on that QRS, but they may not be able to see the P wave no matter what. So they look at these spacing differences. They say, oh, this may be atrial fibrillation, or you may have just thrown what we see down here, a premature beat. Okay, so you may have a normal P wave here, but you threw a premature beat, and that's what's causing the rhythm to be kind of messed up in that area. So premature beats, those happen all the time. So a PAC is a premature atrial contraction. Okay, so and a PVC is a premature ventricular contraction. So if we have a P wave and then a QRS and then a T, and we have another P wave, QRS, then a T, and then we very quickly have a P wave, QRS, maybe it's smaller, and a T. Well, this might be a premature atrial contraction, okay, because we don't have one of those really drawn here, but you'll see it a lot of times. It's smaller, and then, you know, the spacing, there may be a larger one that happens later on. So that's what you might see. We're not going to have to like identify any of them, but that's, you know, this happened a little bit earlier than it was supposed to happen. A PVC, you've got your ventricular here, so this is showing a P wave right there, and this is showing a T wave right there. But then right after your T wave, it throws another beat. But this is kind of a widened QRS because of it's happening from it's that signaling direction kind of thing. So if it's happening from the ventricle itself, if that's sending the signal, or if it's coming from the junction, the AV node, then it's going to have a different kind of deflection, and so it's kind of widened like that, and that's going to be your PVC, or premature ventricular contraction. Okay, so some others. So we talked about AFib. AFib can cause when your atria are fibrillating, when they're kind of quivering and vibrating, they're not really pumping blood actively into the ventricles, and so you kind of have some pooling of blood. So you might get some pooling, and pooling is very bad. Okay, bad. Pooling is bad because then that could form clots, and you might, you know, have it might form a clot, an embolism, might go somewhere else, might go up to the brain and cause a stroke. So there's an increased chance, people with AFib have an increased chance of stroke because this blood flow is kind of not flowing properly, and you have an increase of forming a clot, and then that clot being pushed right up into the brain. All right, let's see. So you give anti-clotting agents, anticoagulants, and if you can't control the AFib, you try to control the AFib. Usually amiodarone is a go-to drug for controlling AFib, and then you give the anticoag therapy. There are various other things that you can do, various surgeries, Mays procedures, ablations, stuff like that, to try to control it too. All right, so VFib can cause death. Okay, you can't function without your ventricles. You know, we're going to see that the atria, you know, are important, but they're mainly important when you're under, when you're like exercising or, you know, strenuous activity. But your ventricles, if they're fibrillating, then that's a shockable rhythm, and you're doing CPR. You're doing compressions with that one. Okay, so we already talked about the premature beats, the PACs and the PVCs. Myocardial infarction, that's where you see an ST elevation, so we're going to learn about that, or you're going to probably more in the future than we are now, but you kind of see this ST elevation. You might see an ST depression, so you see the QRS, and then that's the elevation, and then you may see a QRS, and then kind of a depression. And that can mean ischemia. It can mean that you're having some heart conditions that are kind of problematic. Okay, we'll just put it at that right now. But there could be some kind of a blockage, a STEMI, ST elevated myocardial infarction, or a non-STEMI where it's non-ST elevated myocardial infarction. Infarction just means damage. Okay, but yeah. So in patho, you're going to learn about STEMIs, non-STEMIs, that kind of thing, and that's what we're talking about, ST elevated myocardial infarction. All right, So heart blocks, so let's talk about those. Normally in the heart, you have your atria again, and then your ventricles down here, okay, septum, ventricles, okay, all right. And then you have your SA node, and it sends a signal down. Then you have your AV node, and then your left and right bundle branches that go around, okay. So if there is scar tissue, okay, we'll make it green for bad. I don't know why green is bad. Grass is green and it's good. But we can say that there's some scar tissue here. So when that signal is trying to move through, it's being interrupted. Okay, it's being interrupted, and it could be slowed down. It could be stopped completely. So there are different degrees of heart blocks, but that's what we're talking about really in general, is the blockage of that signal moving from the atrial area down into the ventricle, excuse me. So a first degree heart block may mean that it's just slowed down a little bit. So if we make it pink now, so the signal may be getting through, it's just getting through more slowly. So it's already slowed down in the AV node, but it may be getting slowed down a little more than it should. So whereas normally your P wave, if we look over here on this graph, may occur here, and then, well, that's not very good. But if that P wave, so if we're drawing a normal wave, we might see the P here. Okay, and then there's our QRS, and then the rest of it. Okay. Now, but you can see that this P wave, instead of being here, which is normal, that's normal, N, it's early. Actually, I shouldn't say it's early, because that's not what's happening. The QRS is late, because here's the SA node. The SA node didn't do anything wrong, so it's like, don't say I'm early, it's the ventricle that's the problem. So the atria sends the signal down, and then it's delayed here. And so that QRS complex comes way later. And if it's more than 0.2 seconds, then we say that it's a first degree. So every time in this first degree block, the QRS, the ventricle, is responding every time. It's just taking that signal longer to move through that septum, move through that area between the atria and the ventricles. Okay, so we call that a first degree. So first degree block is where you still have the ventricles are still responding every time. And then you have two different second degree blocks. One second degree block is like this one right here. This first one is normal. That's what I was kind of trying to draw up here when I was drawing the P wave here. So we can see that it's normal. It's less than 0.2. That's great. But then it gets a little bit longer. So there's something wrong that's preventing that signal from moving through there. So then it gets a little bit longer here. It's a little bit, I don't know if it's over 0.2 maybe. This is definitely over 0.2, so it's even longer here. And then it drops it completely. So longer drop, or longer drop. Then you have a winky buck. So that's another name for it, is winky buck. But we're going to call it second degree type 1. Type 1. So second degree type 1. So our Mobitz type 1. And that's when it's that longer drop. And it's also called a winky buck. So second degree AV block type 2, that's where it's there isn't the progressive widening. It's just an intermittent drop. So here we see our P wave is fine, but then our P wave hits here and there's nothing. So there's no ventricular response. Okay. But then it starts up again, we have a P wave, and then it gets through. Okay. So different kinds of damage, different kinds of, maybe progressive damage, or different areas. But anyway, so that's the Mobitz type 2, or second degree type 2. And then down here we have a third degree, which is where everything's independent. So that signal, and I'll draw it up here. I wonder what happens if I use the erase function on that. Oh. That signal that we had between the ventricle and the atria is completely blocked. There's no signal happening. Nothing is getting through. So now we have the atria that are doing their own thing. So they've got the atria, the SA node is like, hey, things are fine up here. It's sending out its signal. The ventricles are not getting anything. They're not hearing anything. So their own autorhythmic function is going to kick in, and they're going to send out a beat. But it's going to be a lot slower. Okay. So then on an EKG, you just see your P waves are regularly spaced, and your ventricles may be regularly spaced, but they have nothing to do with each other. They're all just kind of doing their own thing independently. Okay, and so that's the difference there. I'll tell you on an exam, if you have any of these, it will be very, very obvious what it is. I will tell you that it's wider. This is not an EKG test where you have to kind of analyze it and pick out, you know, subtle differences. I just want you to know the basic meaning that the first degree block, you're getting a response every time. Second degree blocks, every now and then the QRS doesn't fire. And then the third degree block, it's all independent. Top and bottom, atria, ventricular are independent. Okay, so let's get into our cardiac function, our cardiac cycle. So first of all, definitions. I just wanted to write something in green. And there's pink. We'll underline it in pink. All right, so pressure and volume that's just a title because I needed one. So we need to identify what diastole is, the term diastole. So I think we've all heard diastolic, systolic, diastolic. The term is diastole. Diastole is a relaxation phase. Okay, so relaxation, diastole. Contraction, systole. Okay, what happens during relaxation of either the atria or the ventricles? But really, we're mainly talking about ventricles when we talk about filling. Okay, so I mean the atria, they relax to. They don't really fill. They relax, so blood will kind of build up in them, and then they squeeze blood down to the ventricles. So when we talk about relaxation and diastole, we're mainly talking about the ventricles, but they fill up with blood when they're relaxing. Blood moves in, and then they contract, and that's emptying, and so they get rid of all their blood, or they get rid of some of their blood. All right, so after diastole, so we should think about this. So in diastolic volume, well, we already just said that diastole is relaxation. So in diastolic volume must be how much blood is in there after it's done relaxing. It's relaxing, it's kind of taking it easy, and in that time, blood starts to fill. So that end diastolic volume, how much blood is in the chamber after filling. Okay, so that's our that's what that is. And then the end systolic volume. Okay, so this also can make logical sense. Well, systole is contraction and squeezing out the blood. It's how much is left after a contraction. Okay, now this I have, for example, 50 milliliters, and up here 120 milliliters. So in diastolic volume, you may start out. We also call that preload because we're preloading. We're kind of stretching out that ventricle and preloading it with blood, and so we're saying that's maybe about 120. That's kind of an average that's thrown around and used a lot. And then the end systolic, after contraction, we still have some left. Okay, so usually you squeeze out just over 50% of your blood at rest. You can squeeze it all out if you're exercising or strenuous activity kind of thing. But in general, we're talking about at rest. So if we have a certain amount of blood, so if our end diastolic volume, so let's draw just a ventricle here. Our end diastolic volume, let's say we have this much blood in it. Okay, and we're going to say that's 120 milliliters. Okay, and then it squeezes. This is a squeezed ventricle, and after it squeezes, it has, what should I use? It has 50 milliliters of blood, 50 milliliters of blood. Okay, so this is our end diastolic. Okay, so it's relaxed. It says, hey, put however much blood you need in there. Okay, we also call that preload. And then it squeezes, contraction. So this is end systolic. It's done contracting, and it still has some blood left in it. So how much blood did it squeeze out? 120 minus 50. So it squeezed out 70 milliliters. Okay, so that's how much it squeezed out in one stroke. No, in one stroke. Okay, so that's the volume that it squeezed out in one stroke. So that's what we're getting to is end diastolic volume minus the end systolic volume is going to be your stroke volume. Okay, so that's what this equation is. So stroke volume is that difference between the end diastolic volume and the end systolic volume. So if you're in diastolic, you had that much, you squeeze out some of it. You want to know how much did we squeeze out? Well, subtract those, and then we can, because we can maybe see how much blood was in there in the beginning and how much blood is in there in the end, and then we know how much blood left. Okay, so with every beat, the heart pumps about 60% of the blood in its chambers, or about 70 milliliters, so that worked out. And this is important to preload, afterload, and contractility of the heart. So we're going to learn about those in a couple of slides. Preload, afterload, and we've already kind of talked about contractility. So you need to know your stroke volume. Stroke volume is just how much the volume of blood ejected in one contraction. It's a very simple concept, but if you're not familiar with the term end systolic and diastolic, then you have to kind of practice those and let those into your brain as being normal words to use. All right, pop up. I don't know if you can see it. All right, so let's see, cardiac output is the amount of blood pumped out of each ventricle in 1 minute. It is the product of heart rate and stroke volume. So cardiac output equals heart rate times stroke volume. So this is what we're going for now. The only difference between stroke volume, so stroke volume was one beat or one contraction. Cardiac output is over 1 minute. Okay. So there we go, 1 minute. So that's the difference, because that gives us a little bit more information, I guess. So, your stroke volume may or may not vary, but if you really want to see how much blood is being pumped, you just take it over a minute and you say, okay, my stroke volume may be 70, but your stroke volume may be 80. And so we have to kind of consider how fast our heart is beating to kind of compare those, because just because your stroke volume is higher than mine, my heart might be racing, and I may be pumping a whole bunch of blood. Okay, so that's why we look at cardiac output, because it does consider the heart rate. And of course, when you're trying to control blood pressure, heart rate definitely has it plays a role, because your beta blockers. Your beta blockers are going to kind of lower your heart rate, and then there's some other medications, maybe your calcium channel blockers, they may decrease that stroke volume a little bit. Okay, let's see. So normal cardiac output is 5.25 liters per minute. In a healthy system, your stroke volume is fairly consistent. If blood volume drops or the heart weakens, then your stroke volume declines, and cardiac output is maintained by increasing heart rate. So what we're saying with that is that sometimes people's heart starts to fail. It gets weaker. It gets weaker with age. It gets weaker with, disease. After a heart attack, it may be weaker. And so, the body will have to compensate to pump more blood, so it will have to beat faster. Okay, so that's a compensation that kind of happens when demand comes up and says, hey, we need more blood to flow. All right. So, couple of things here. The heart regulates itself without hormone or nervous system input. It has intrinsic control. What does that mean? Because we already know that we can speed up the heart and we can make the heart beat harder, increase contractility, by activating the sympathetic nervous system, and that's true. Or the parasympathetic to, slow it down. But on a minute-to-minute basis, without any input from the sympathetic or parasympathetic nervous system, your heart has a certain amount of control, and it's all kind of accidental, and it's based on this thing called the Frank-Starling law, or the Frank-Starling relationship. Okay. So if we remember, okay, so let me just get this out of the way real quick. Preload is that end diastolic volume we were talking about. How much blood moved into the ventricle during diastole. So the ventricle was relaxing, a bunch of blood moved in, maybe the atria kicked a little more in, and so there's a whole bunch of blood in there. We'll say 120 mils just because we like to say the same thing over and over. So there's 120 milliliters of blood in there, and we're ready to squeeze it out. That's our preload. That's how much we have, okay? So let's say that our preload was less than that, okay? So this is our end diastolic volume here on the x-axis. Let's say our preload was clear down here. This is all we had. Let's say 120 is like up here. Okay? I don't know if that's even accurate, but maybe 120 is here, right? But let's say it's down here where it's lower. Then what happens is that if you recall from skeletal muscle, when you have all of your myosin lining up on your actin, so if your actin filament's here we'll draw this differently. So you want to have maximum contact of your myosin with your actin. You want to be the more myosin, so this is actin, this is myosin. And remember, cardiac muscle is also striated, so it has they all have the actin and myosin, but it works the same way as a skeletal muscle. So that means that if it's really stretched out, like over here, then that actin may not, all those myosin, it may be too stretched out, it may not even contact with it. So as it gets longer and shorter, remember that if we have our muscle almost completely contracted, it's going to be harder. You're not going to have as much force to kind of make that contraction. What we like is it when it's kind of right in the middle, okay? So if we think of a muscle and we think of an arm, okay, and there's a fist, so this is an arm. This is a very skinny arm. There we go. That's not much better. Oh, there we go. It's gone completely. All right. So if we're contracting our bicep muscle, we have a lot of strength right in this kind of area. Meanwhile, if it's really stretched out, this is our hand up here with our fist. I'm such a terrible drawer. If it's really stretched out, then that's not going to have that contact. That's where your actin and myosin are going to kind of fall apart from each other. Or if it's too contracted, then that's too much too. Okay, so we kind of like it in that middle area, and it's the same with the heart. Okay, and that's what this graph is trying to show you. It's trying to say, okay, when the ventricle is really stretched out, so there's more blood, more preload, right here's kind of a sweet spot. If you look, you can barely tell that, but the actin and the myosin are lining up really nicely at this area. So this is our optimal stretching of the ventricle. Okay, so that's the amount of blood in there. It's stretched just right. Okay, but if we stretch it too much, this is very dramatic, then you don't have good contact. You can kind of see in this picture your myosin and actin aren't lined up very well. So that's not good. But you can see along the way, as you add more volume, and this is kind of where we started here, as you add more volume, you have more strength, basically. Okay? So if we just have a little bit of volume, well, or a little bit of preload, and we're not going to be able to, we don't have to squeeze as much out, but also you're not going to have as much strength to do so. So it works out just right. Okay, and then, if we have a little bit more blood in there, we have a stronger contraction. So our stroke volume is going to go up. We're still not, pumping out all of it, but, it doesn't matter. So then we get up into this optimal area, okay, and our stroke volume is going to be even harder. But then we can see that now we're over here, we're stretching it too much, and that's not good. Okay, so if our preload is too high, then that can cause kind of weakness. But in this nice little area here, that sweet spot, that's exactly what it's supposed to do. more blood, higher preload means a stronger contraction. Okay, so that's what we mean by intrinsic control. It's saying that if you give me more blood, I will pump more blood. You know, less blood, I'll pump less blood. Okay, so let's see the way that it's written here. So in heart muscle, more stretching, a higher preloads means a more powerful contraction. Okay, it's our ideal right there, but only to that point, because over here it starts to fall off. That's not good. So more blood, so your ventricular preload, is the amount of stretch caused by blood entering the ventricles. So the more blood, the more powerful contraction, but that's only up to a point. Okay. So that's our preload. So if we're doing definitions, we're going to come back and talk about Frank Starling again. But if we're talking about preload is that volume of blood that initially goes into the ventricle. This is a ventricle again that I'm drawing. That's our preload. Now, afterload is different. Okay. So if I'm going to draw a ventricle down here, and I'm going to preload it with 120 milliliters of blood. Okay, we're gonna erase the rest. We're not going to worry about the rest of the. This is our aorta. I know this looks like some kind of a flask in a lab, but it's not. So this is definitely the aorta and a ventricle. I don't know how you can see anything else in that picture. So there's our aorta. So let's have somebody else over here with an aorta. So we're going to make everything the same, except, so we've got, let's go ahead and use our 120 milliliters. That's our preload. Okay, that's the volume. So our preload volume is the same in both, 120 milliliters. Well, this one over here has a very low afterload. So this guy here, the afterload is fine. This one over here has a lot of resistance. Okay. So they've got some arteriosclerosis, they have some plaques building up, you know, down in the vessels. So it's going to be harder in this case to move blood through. Okay, so our blood is going to, so as we try to push blood through, it's going to kind of all push together. Meanwhile, this one, wide open path, just great, fantastic, great vessels. Okay, so this is low afterload. This is high afterload. So no, we're not talking about any kind of volume of blood. We're talking about resistance to flow. Okay. So afterload is pressure caused by that resistance of the aorta. So how hard, so when we talk about the afterload, we're talking about what's going on with the ventricle. We're saying how hard do you have to push ventricle to move blood through? Now, if we have a lot of resistance, you're going to have a really high afterload. You're going to have to push harder. If we don't have much resistance, you don't have to push as hard. Okay, you have a lower afterload. Okay, so that's our difference in that area. So a higher afterload, you know, we can try to increase. So this heart's going to, you know, over time, you know, if there's high afterload for a long time, this heart's going to thicken, it's going to hypertrophy, it's going to get stronger and stronger. But it's still, if it's pushing against resistance a lot, and some of that is going to kind of move in there, it's not going to be able to push out as much blood every time. Okay, so yeah, it's trying, but what's going to happen when you have that resistance is the fraction of blood that it's going to be able to push out is less. So it's going to have, so there's going to be probably a lower stroke volume. So decreased stroke volume. All right. So for preload is the blood moving into the ventricle. Okay, and we already said that if too much blood, if our preload is too high, then that's not good. Then we're going to have less blood being forced out because it's not going to line up right, and that initial contraction is not going to work very well. So So yeah, so we might want to think about, why do we have too much preload? Why is our preload too high? Maybe it's probably, could be because there's too much fluid built up. The heart may not be working right, so it's backing up into the veins, or it's backing up into the lungs, and so it's trying to force more blood in to get it through. It's just kind of congested. So if we talk about traffic, we would say it's congestion. So we have congestion that happens the same way with blood. It's like congestive heart failure. So that blood backs up. So we may need to reduce the amount of fluid, amount of blood, and that can help lots of different things. Dilation of the veins can help. All right. So let's see, where are we? So let's see. So we talked about preload, we talked about afterload, and I have here different drugs affect preload or afterload differently. Well, if you can open up these arteries, that would be good. Cause some vasodilation of the arterial vessels. That can lower the blood pressure. It can kind of allow less resistance and allow that blood to move through. Meanwhile, we just said that if you have a high afterload, a lot of times that's because there's too much blood, and we can kind of lower that with diuretics or something. Lots of options. Okay, so we are looking at a graph here, and this graph has on the y-axis, it has ventricular pressure, so how much pressure is built up in the ventricles. Okay. And then we have on this x-axis, we have the volume of blood, your end diastolic volume, or your preload. So let's just look at the x-axis first of all. So if we're looking at our ventricle and we're saying there's more blood moving into it, this is our preload, and we've got more and more pushing in, coming in, then we can see that it's going to build up pressure as it comes in, okay, until it kind of reaches a maximum point and it's full. Okay, and so that's our preload. So we've reached our preload here, and then, okay, if you've already been through this is going to kind of make sense maybe. Then kind of jump up here because the ventricle starts to squeeze. This valve pops open and it squeezes the blood out. So now our preload, all of our blood is leaving. So the volume is going down and the pressure is going down because we're getting rid of that blood. So this is kind of a introduction to the whole left ventricular mapping that we're going to do. So on this x-axis we're filling, and then we filled it as much as we're going to, and then it starts to squeeze, valve pops open, and now instead of the volume going up in the ventricle, it's leaving, so the volume is going down, 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 and the pressure is getting lower and lower and lower. And now it's squeezed out as much blood as it's going to squeeze out, so then it's relaxing, and then it's time to do it again. Okay? All right, so that's what we see there. And here, so we can see the volume in the ventricles is increasing, okay? And then the contraction happens. So this is showing the contraction, and then, so this is showing that an increase, and this one kind of shows it too. This one also includes that isovolumetric phase though. But you can kind of see an increase here, but this is showing it differently. Increase, tension is squeezing, and then the pressure goes down and the volume goes out. Okay, so we're gonna look at graphs like that again in a little while. Okay, so Frank Starling and inotropic agents. So remember, Frank Starling is saying that if your vessel, if your ventricle has more blood, it's going to be stretched more, which means it's going to have a stronger contraction. So more blood, stretched more, stronger contraction. Less blood, not stretched as much, and it's going to have a weaker contraction, which is fine because that's what you want to do. But now we mess with it. Now we give drugs that say, okay, we're going to give the same volume here. So this is the volume, our end diastolic volume, and we could put this line anywhere. We're just going to pick a certain volume. Let's say 120 milliliters. Come back to that. So our ventricle fills with 120 milliliters. Now, if you have something, if so, let's say your patient has high blood pressure, so you give them a negative inotropic agent that causes their heart to not maybe beat as hard. Okay, so it fills with the 120. It's blue blood. It's weird. And then when it squeezes, it's not going to squeeze out. The stroke volume isn't going to be as high. The stroke volume is going to be lower because it's not going to squeeze as hard. Okay, that's what inotropic means. How hard is it squeezing? Meanwhile, if you give a positive inotrope, let's say that somebody has heart failure. Okay, so we give them digoxin, and which is not the most common, I don't think, for heart failure. Not the most common treatment, but either way, 120, and then, but we have a positive inotrope, then they're going to squeeze out more. All right, so that's what this graph is showing. It's saying negative inotrope. So if we have the control or normal before any kind of treatment, that's what our graph looks like. Meanwhile, same volume, with a positive inotrope, you're going to have more output, and you're going to have less output with a negative inotrope. Okay, kind of something we expect. All right, I'm not going very fast. So let's see, intracardiac pressure. So this is something to take a look at. So I pointed out a couple of things in different chambers of the heart and different vessels. You're going to have different pressures. So we kind of know that because the whole right side is under lower pressure than the left side, because the left side is squeezing out to the systemic, to the body. Meanwhile, the right side is squeezing out to the lungs. So the systolic range in the left ventricle, it says here 90 to 140. That's fine, because that's really kind of our systolic pressure. But when the left ventricle relaxes, goes almost down to 0. Okay. Or it goes very low. This is saying an average of like 7 millimeters of mercury. But the left ventricle is squeezing into the aorta, and when the left ventricle relaxes, it's really, there's less blood flowing into it. It got rid of most of its blood, and now it's ready to take on more. And so it's going to allow blood to just kind of flow into it. So it makes sense that the pressure lowers a little bit. However, when you get up into the aorta, which is here with the AO, when you get up into the aorta gets that blood, that 90 to 140, so 96 to 140 pressure, and then it has to kind of deal with it. It has to kind of push it into the arteries. And so when it pushes it into the arteries, it's just recoil of that elastic vessel. But it's never going to get it to the point that it's just close to 0. It's always going to have some level of pressure, and then the left ventricle is going to push more into it. So that the aorta kind of maintains what we think of as your normal blood pressure. So like 120 over 80. Okay, so if we take systole, and diastole, that's going to be your normal blood pressure. Because it's in the system now, and there's only so much room in your vessels for blood, and so it's going to be constantly under pressure, high pressure, and then lower pressure, but still pressure. All right, because we have to keep that pressure, because we have to maintain the perfusion of the organs. Okay, cardiac cycle. So cardiac cycle is what we call that repetitive contraction and relaxation of the heart chambers. It's basically your heart beating, but we're going to go through and we're going to say what's going on at every phase. We're going to move through it with the blood, and we're going to talk about what's going on with the valves and when they're open and when they're closed. So we remember that the heart has 2 pumps that work together, right and left. So what's happening on the right side is happening on the left side. I showed you the pressures before, so we know that the pressures are different, but the activities that are happening in the heart are the same. Okay, so blood moves through the circulatory system from areas of high to low pressure. Has to, because if it was the other way around, the blood would flow the other way, because it always is going to flow from high pressure to low pressure, and the contraction of the heart kind of keeps doing that. So what we're talking about with the cardiac cycle is it's a cycle. So anytime you have something that's cyclical, you can start anywhere. So we're going to start right up here with blood has already kind of moved into the ventricle. So we're going to have the black blood here. So we have the ventricle is already kind of filled with blood, and now we're ready for, so there's more blood coming back from the lungs, and the atria is going to push a little bit more in there. Okay, so that's our first one. So atrial systole. Remember, systole is contraction, so the atria is contracting. Okay, so depolarization of that SA node, so this is why we start here. So depolarization of that SA node is going to send that signal to the atria and tell it to contract. So these are our atria up here, and then our ventricles are down here. All right, so it sends that signal and tells the atria to contract. So the atria contracts and pushes blood, more blood, into the ventricle. Okay, both ventricles, both sides. Okay, the left ventricle and the right ventricle. So, so obviously, if the atria is pushing blood into the ventricle, the mitral valve on the left side and the tricuspid on the right side are going to be open. And the exit valves, which are the semilunar, which is the pulmonary, and the aortic valve, are going to be closed. Because if they weren't closed, I mean, if it wasn't this way, nothing would work. The atria is pushing blood into the ventricles, so that mitral valve, we're looking at the left side, that mitral valve has to be open, but that pulmonary valve better be closed, or I'm sorry, the aortic valve better be closed, or the blood that's being pushed in there would just go straight into the aorta, and there would be just chaos. So, so it makes sense. The mitral valve is open, the aortic valve is closed. So I have a couple of facts here. At rest, contraction of the atria is really not necessary for heart function. So if somebody's just sitting around, then they really don't need the atria. It's still doing its job, but it's not necessary. It's only when you're under, you have, strenuous exercise kind of thing that you have a need for that atria to kind of push more blood, and, because you're using more blood, you're pumping more blood. So the atria then becomes important. That's why with AFib, a lot of times people may not realize they have it unless they try to, get up and walk up some stairs or mow their lawn, because the atria isn't that important. I mean, the atria is important, but it's not used as much when you're during relaxation. Okay, but during exercise, atrial contraction is necessary for function as the heart pumps 300 to 400% as it does when it's at rest. So 70% of that the filling of the ventricles happens passively. Passively means that you're not pumping anything into it, which means that blood is just flowing from either the body through the vena cava on the right side, or from the pulmonary arteries on the left, or pulmonary veins on the left side from the lungs. So it's just kind of passively moving in there. All right. So then you have blood that has moved into the ventricle. Okay? So if we draw our ventricle again, and we put the blood in there. So now we have this period of isovolumetric contraction. So I'm going to have to stop changing colors because it's going to mess with things. So we already know that leading out, our aortic valve is closed. Okay, so no blood is moving out. So, but pressure now has built up. So we have an increase in pressure in there, and so we have these valves, mitral valve, okay, bicuspid. So they're my two cusps, and when this starts to squeeze, if this ventricle starts to squeeze, it's immediately going to push those valves shut. Okay, so now we have the mitral valve is closed and the ventricle is starting to squeeze. So now all the valves are closed. So semilunar, which is, if we're talking left ventricle, is your aortic valve. On the right side, it's the pulmonary valve. And the mitral valve and the tricuspid are also closed now because we started to squeeze and we pushed that valve closed. So now it's going to, so we call this isovolumetric because we've got squeezing, but there's obviously no change in volume. Okay? okay, because the blood isn't being pushed out because the valves are all closed. So we have the squeezing, this increase in tension that's happening despite any kind of change in volume, no change in volume. Okay, so the ventricular muscles start to contract, increasing the pressure inside the ventricles, causes the AV, mitral, and the tricuspid valves to close. Semilunar valves were already closed. They had to be. We saw that last time. They have to be, or it would just flow right through. And so we have that amount, 120 milliliters of blood in the ventricles left from that last diastole, and it's not, that's our end diastolic volume, and it's not changing because the valves are closed. Okay. So that's what we mean by isovolumetric. Isovolumetric means that the volume isn't changing, but it is a contraction, so our pressure is increasing. Okay. They're very brief, so isovolumetric periods are very brief. No blood is moving because all of the valves are closed. So this is another picture of kind of how that works. So this was a buildup. So this is, let's say, a mitral valve. Okay, so we're talking left side. So pressure inside was building up, and then when that ventricle started to squeeze, here are your valves up here, it pushed them closed. So this is a one-way valve. So when that fluid, when that blood starts to push against that, it closes them off. You have these muscles with these tendons, chordae tendineae, and the papillary muscles will contract. The papillary muscle is kind of cool. They contract along with the ventricles. They're just like an extension of it. So they get the same signal. It's like we're contracting now. They just happen to be holding that mitral valve closed. And so that contraction that's happening now, the mitral valve is closed, and we haven't yet, we know it's going to happen, but we haven't pushed our aortic valve open yet. But then we do. Okay, so rapid ventricular ejection. So we built up enough pressure, and now we pushed open the aortic valve on the left, pulmonary valve on the right, and together those are just called the semilunar valves. Okay, so we pushed it open. Our mitral valve is still closed. Okay, AV valves are still closed, but now our aortic and pulmonary valves are open. So we have rapid ventricular ejection, and then we push out so much, and then it kind of slows. So that's why followed by a reduced ventricular ejection. We're gonna keep it simple. We're just saying we're pushing the blood out of, and you can kind of see that squeezing that takes place out of the ventricle. So it pushes the cusps of the semilunar valves against the walls. Basically, it's opening up like a I don't know, like a saloon doors or something like that, pushing through, and there we go. Blood's moving now into the aorta or the pulmonary artery. So blood is ejected from the ventricles. The pressure in the two ventricles are different. We know that. After that first initial spurt, the pressure starts to drop, okay, in the ventricles because it's getting rid of the blood, and there it goes. It's going up into the aorta. The ventricle doesn't have to worry about it. And then at that period of ejection, you have some blood remaining. So it says 50 to 60 milliliters are still in there. You pushed out about 60%, or half, as it says here. Whatever, varies. And now we're ready to relax again. We just did something big. If we're the aorta, we just did something big. We pushed blood. We deserve a break. Okay, so now we're going to relax. So when we relax, what happens, so here's our ventricle. We just squeeze blood into the aorta. The valves are open. Oops, that looks terrible. I'm going to draw this in black. Okay. So, okay, our mitral valve is closed over here. Okay, so we're just going to kind of focus over here on the aortic. So the valves were open, and our blood was pushed. We just squeezed our blood through. So now our blood, we're going to say there's a little bit left in here. Our end systolic volume, which we're saying is about 50 to 60 milliliters. But most of our blood is up in here, in the aorta. We just pushed it up in there. So then when these guys, when the ventricle starts to relax and says, okay, we're going to take it easy now. We just did that. That was us. We did that. We're good. That blood's going to be like, whoa, look at the pressure down here. It just dropped. That's relaxing. And what that's going to do, so maybe we don't want any of the blood to pass through, but what it's going to do is it's going to push these valves closed. Okay, and that blood's not going to be able to move. The only way it's going to be able to go is out to the body now, or to the lungs on the right side. Okay, so that's just how it happens, and now we have this period of resting time. Okay, so the relaxation, the diastole of the ventricles, okay, which is the next step. So we just saw that the semilunar valve, that aortic valve, closed because we pushed blood into it. The blood said, whoa, let's go back. And the valve said, no, you can't. And so now the blood is going to move on to the body. The mitral valve was already closed. Okay, so nothing was getting through here. So this valve was already closed. So now we have our second isovolumetric phase, but in this case it's relaxation. So the ventricle squeezed blood out. So when it squeezed, it pushed that valve open, and now the valve is closed and the blood is gone except for whatever the bit that's remaining, and it's relaxing. Okay, so this is completion of T wave. Remember our T wave, our P, QRS, and then the T wave. That's repolarization of the ventricles, which is going to be associated with relaxation of the ventricles. Ventricular pressure starts to fall very rapidly, and as it falls, okay, so as the ventricle relaxes more and more, the pressure is going to get lower and lower. And remember, we have blood coming back from the lungs on the left side, from the vena cava on the right side. Okay, so we have blood constantly kind of coming back there. So as that pressure falls, even though during this phase, isovolumetric ventricular relaxation, all the vessels, all the valves are closed. As that relaxes, the pressure out here will get too much, and it will push that mitral valve open, and that is our next phase. So now we again have passive ventricular filling. So now our mitral valve or tricuspid are being pushed open because that ventricle has relaxed, pressure is lower, and the blood will then start to passively move in. Okay, so these open. So their AV valves open, and those semilunar valves are still closed. All right, and then the next phase is for the atria to pump blood in. So active ventricular filling. Passive just means that blood is just kind of flowing into it, and that starts us over with the first part of it again. So the first part of the cycle. So if we kind of put all of this together, so we just finished with the cycle here. Let's make sure we read everything. Blood flows into the relaxed ventricles, accounting for most of the ventricular filling. And then we start our phase over, and we have active filling, which we called, what? Do you remember? Atrial systole. Okay? That's it. Active. That's the word. Active filling. Atrial systole. That's our next phase, which was our first phase when we started. All right. Let's see. So this is kind of the whole thing. Your book. This book kind of has a couple of sections that I just kind of combined these: the rapid ventricular ejection and reduced ventricular ejection, and the rapid ventricular filling and the reduced ventricular filling. I just kind of called that ventricular filling. But the book kind of separates it and shows that it kind of rapidly starts out. So B is rapid ventricular filling, this area here. That's the ventricles, this big one. And then it kind of slows down here in C. Okay, so I just kind of put those together. So we said, yeah, it fills, it reaches the end diastolic volume, and then it starts to, let's see, isovolumetric relaxation. Yeah, so let's see, that was volumetric contraction, rapid. Oh, it squeezed the blood out. Sorry, the volume, it squeezed the blood out, not filling. So anyway, you can kind of go through this. I don't want to spend too much time on it, but it empties and then it fills again. And this kind of breaks it down for each of these steps and what's going on at each of these phases, including the valves closing, which is causing the sounds that you hear when you listen to the heart. So this over here is kind of the same thing. We have this, except now it's putting it along with the EKG. So we call this a Wigger diagram, named after the person who developed it and or first did it. I don't know, now everybody does it, so I don't know. But that's what you'll hear it called. So we have the P wave depolarization, and then you have, let's see, systolic pressure. Let's see, so this should be the pressure from contraction. Yeah, so this is contraction of the atria, or the ventricles. That's the big one. And as you have contraction of the ventricles, you can see the volume is decreasing, okay, until you get to the end systolic volume, and then it fills again over here, and you have the end diastolic volume. So you have the passive filling that happens here, and then the atria adds more to it, and you have your actual end systolic volume, and then it starts over again. And you can kind of go through each of these for each part of the cycle, and you can look at which valves are closed, these periods of isovolumetric contraction and relaxation. So I have a couple of these to look at. This one's looking at pressure in the aorta. So here's the aorta, and as it fills, okay, so actually as it empties, it's kind of moving out through pushing things into the veins, and then when the ventricle contracts, it fills it very quickly. So now the aorta is getting a bunch of blood, and it starts to then release that blood again, and then it's filled again. So that's kind of looking at what's going on with the aorta, and it's going to, the pressure, I think that's the important thing, is the pressure never drops below that diastolic pressure because it keeps getting filled. So it's always got that positive pressure. So even though the pressure in the ventricle can drop to almost zero, okay, diastolic pressure in the ventricle drops to almost zero, that doesn't happen with the ventricle or the aorta because it's continuing to push blood forward. This is kind of pointing out the closing of the vessels, or of the valves, and when those valves close, so when the AV valve, so when that mitral valve closes, that's the first heart sound, then you have that's when you have that turbulent flow and you hear that sound. And then when the semilunar valves close, you hear a sound then too. So remember, that's when the aorta, is filled with blood, and then it's the high pressure, and it says, oh, we're going to go back to the ventricle because look, it's starting to relax, but those valves slam shut. And when they do, they cause a bunch of turbulence, and that's what you can kind of hear that with your listening ears. All right. Let's see. So then, yeah, there's your left ventricular volume, and your atrial kick kind of there. Okay. So we'll look at a couple of more things, a couple of more graphs. So this is kind of goes along with the graph we looked at before, the Starling graph. And we can see that there is volume increase is on your x-axis, or volume increase or decrease is on your x-axis, and your pressure increase and decrease is on your y-axis. So if we move through the entire process here, we can see that we have an increase in volume. Okay, so this is going to be associated with filling of the left ventricle. So this is all from the perspective of the left ventricle. If we're in the left ventricle, we can see, okay, pressure's increasing a little, okay, not much, okay, but you have that movement of blood into the ventricle. All right, and so we have that increase in volume. And then once we have end diastolic volume, then the vessel, the mitral valve, will close, and we have isovolumetric contraction. So we have a pressure increase, but it's isovolumetric, so there's no volume change. Left and right is volume change. Okay, so there's no volume change, but there is a pressure change because the ventricle is starting to squeeze. Well, then that aortic valve pops open and blood starts to move into the aorta, and so we can see that the volume decreases because blood's moving out of the ventricle and into the aorta. So initially when it starts to squeeze, it's high pressure, but then as it empties, it's lower pressure, and now the blood is in the aorta. Okay, has moved out of the ventricle, and again the blood tries to move back from the aorta, but it shuts that valve. The aortic valve closes, valve closes, I don't know what that is, and then you have that period of relaxation. Okay, so you have relaxation, isovolumetric relaxation of the ventricle, and then it starts over again. The mitral valve opens, you have the filling, and then it fills, and so this is our whole cycle here. So we had the Frank Starling curve here that shows that as you have more volume, you have a stronger contraction, and that's going to match up with it. But really, we're talking about, how can we use this information to kind of give us to kind of see what's going on with the heart. And so let's kind of look at some of these differences. So dynamic effects on left ventricular loops. Okay, so that's what we're talking about, is the left ventricular loops. So the width of the loop is volume, so stroke volume. So if we start here at this point and we say, okay, this is our end diastolic volume. Okay, this is how much volume is moving into the ventricle. Okay, so remember our x-axis is volume. So we went from not having very much in the ventricle to having this much in the ventricle. Okay, so we're increasing it a little bit, so we have increased preload. So we increase the preload, well then, in this case, it's going to squeeze it all out, which means that we have also increased stroke volume. Okay, so we increased our preload. Frank Starling says that if we increase our preload to a limit, as long as we don't increase it too much, we'll have an increased stroke volume. Okay, now remember, afterload is related to pressure or resistance to flow. Okay, so that means you have to create more pressure to get it out. So in this case, we have filling of the left ventricle, because we're always the left ventricle, because this is a left ventricle loop. And then we have, okay, so this is interesting to look at. So then we have the pressure builds up, the mitral valve closes, the aortic valve was already closed. So we start increasing pressure. That ventricle starts to squeeze, and it says, okay, I'm going to open this. Well, open that aortic valve. Well, before, the aortic valve opened right here. So now we're kind of wondering, what's going on? Because we're still pushing, squeezing, the heart is still squeezing, more and more pressure, and then the valve opens. So the aortic valve opens. So what was happening is that we had increased afterload. So the aortic valve was still there, it was still full of blood, but the pressure up there is higher. So this is higher blood pressure. It would be seen as higher blood pressure if you were taking the blood pressure. So it's taking more force to get that valve open because the pressure is higher. But it does, eventually you get to that point where you've squeezed it enough that the pressure that it opens, but then you kind of move into this area here where you only have so much time to get that blood out, so you have less volume. Okay, so your stroke volume is going to be lower. Okay, so your pressure was higher to get the valve open. The pressure's higher to push blood into it. That's higher preload. Okay, increased afterload, and so the volume that you're going to be able to get out in that amount of time is going to be reduced. Okay. And this one, the last one, is increased contractility. So if we start out here and we squeeze and we load, that's our preload again. preload, so we're preloaded, and now the mitral valve slams shut, okay, and our aortic valve was not open yet. So we're going to start squeezing, we're going to push, 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 and then we open, the aortic valve opens, valve opens, valve opens, and we start to squeeze, but this time we're squeezing harder. So we're pushing out more blood more quickly, harder, 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 and then we filled the aorta. We've pushed more blood into the aorta. That pressure, stops. The ventricle starts to relax. The valve slams shut. Okay, so the aortic valve closes and it rests. So the aortic valve is closed, and then you're just waiting for enough pressure, so for the pressure in the ventricle to decrease, so the mitral valve will then open. And then you have, so you were able to pump more blood. So you have more calcium in the myocardiocytes, the heart muscles, and more calcium in them. And that it pumped out more. So good job, heart. All right. And we can see that because there's your stroke volume. Your stroke volume is always going to be this right to left volume. That's how much it squeezed out more. Okay. Yeah. All right. So this is just kind of something to go through to kind of look at things. So really, we're kind of done with these slides. Just a couple of extra slides for your learning, enjoyment, pleasure. So greater ventricular, so increased, so preload, if it's increased versus decreased, you've increased preload, you have that higher stretching, which means that the Frank Starling law says, or relationship says that more stretching means that you're going to have more contractile force capability up to that point, unless it's overstretched, and then it kind of goes away. Decreased preload means you're going to have less force, decreased left ventricular and diastolic pressure, so there's less pressure in there, and it's just going to kind of adjust on its own. And then the afterload, decreased ventricular ejection, decreased cardiac output. So that's what we were just looking at. So afterload, remember, is so this is my ventricle, okay, and this is my aorta. I know it looks like that flask. And it's saying that if I have higher afterload, which means I'm not going to let things in as easily, that means that ventricle is going to push, muscle's going to squeeze, but ultimately it's not going to get as much out because it's only got so much time to do it, and even though it's squeezing harder, it's hard for it to make up that difference sometimes. So if your afterload is increased, you're going to have less cardiac output, or your heart's going to have to beat faster. But even then, that may not be enough to cover it. So increased ventricular workload, increased myocardial oxygen demand, lots of things. So this is a lot of times why people with bad arteries can start to have angina. So if you have increased myocardial oxygen demand, but you don't have the blood flow to get it in there, like let's say, your coronary arteries may be clogged and you can't get the blood flow in there, then, that's going to be a problem too. Okay, so lots of things can go wrong there. Decreased ventricular workload, decreased oxygen requirement, increased stroke volume, increased cardiac output. Okay, so we like a lower, decreased afterload. We don't like it to be, clogged up with stuff. Okay, so then heart rate, contractility, we don't have to go over all of those. Abnormal heart sounds, we can kind of read through this. Blood flow should be silent, but when those valves close, it causes some turbulent flow, and that's what you hear in heart sounds. So if it hits anything that obstructs it, so usually we're talking about vessels here. Sometimes if the valve doesn't close right and you have like regurgitation where some blood kind of flows backwards for a second, we can hear that as a murmur. So most causes of heart murmurs in adults are valve problems. If the valve is incompetent, it doesn't close correctly, then you'll hear a swishing sound. If the valve is stenotic or narrowed, a high-pitched sound or a click can be heard. Yeah, so heard all kinds of weird sounds in hearts. All right, and this is kind of just a picture to show what we're kind of talking about. That insufficient valve, so it's kind of flowing this way, but then when it closes, it kind of leaks and blood starts to kind of flow backwards, maybe for just a little while, and you can kind of hear that turbulent flow, and it sounds like that that kind of a sound. Yeah, stenotic valve less, which means less cardiac output or less stroke volume anyway. Okay, that's all I've got.